induction of labor? It's a pretty simple talk. We are just going to talk on various conditions where you do induce, what are the contraindication, how will you manage the complications which are going to happen, and how will you monitor the patient. This is all we are going to discuss in today's talk. Induction means inducing the pain artificially in a patient who has achieved viability. Now, what is the definition of viability? It actually varies from place to place. Like in my setting where I'm working, maybe viability may be 26 weeks or 28 weeks. But if you have, you're working in a very remote place where you don't have neonatologists, there may be a 29, 30 weeks, that may be your viability. But our average cutoff, what we take is 28 weeks in today's era. So when we induce the pain artificially, which causes contraction and helps the woman to deliver, is known as induction of labor. What is successful induction? When you achieve delivery within 24 to 48 hours of inducing labor in any antenatal woman. Before we understand what is induction, we need to understand that you cannot just do induction in anybody. You should have a proper indication for that. You have to look at the checklist. You have to take into account what is the maternal history. You have to give information to the patient what you're going to do, how are you going to do that, and what extra thing which may come up. Like when you start, if you don't tell them about failed induction, if you don't tell them about hyperstimulation, and if any of these complication happens, the patient can ask and question you why you didn't inform me regarding this process. So whenever you have decided that you're going to do induction, first and the foremost thing is to have a specific.
Labor is the physiological process through which the baby is delivered. But how do we know that true labor has actually started? We look for regular, painful contractions and progressive cervical dilatation. True labor is characterized by regular, painful uterine contractions that progressively increase in frequency and intensity, along with progressive cervical effacement and dilatation. Remember, contractions alone aren't enough. The key is progressive cervical change. That distinction is crucial for identifying the onset of true labor.
On oxytocin, if the findings are favorable, then you have to wait for 6 hours before you go to next step. Pessary, you just place it in the vagina, ask the patient to lie there for half an hour, same. But the difference is pessary needs to be stored in refrigerator, not in the fridge, in the freezer compartment of the fridge. Okay, here, if anytime you want to remove it, just pull it off and it will come off. This is the best thing or the benefit you get if you're using pessary. Coming to Misoprostol, see, Misoprostol is actually not approved, but it's the most common medicine. You all are very well aware of that. DGCI doesn't approve that, but Miso is freely available and we all use that. You cannot remember this. This is a chart which you can take a photo, take a screenshot, put it in your, you cannot remember. Just see what is your indication. For example, if you have a fetal demise at 20 weeks, what you're going to do? Okay, fetal demise, 20 weeks, I'm going to give Misoprostol 400 microgram every 3 hourly, buccal, sublingual or PV until expulsion. This is very important. There is no limited, like previously it was said, 5 doses, 6 doses. No, it's not like that. The guideline has totally changed in 2023. You can continue till expulsion happens. So just match the permutation and combination and look at this table whenever you are deciding which route you need to give. Okay. See, buccal and sublingual Misoprostol are recommended for induction for viable pregnancy, but it is associated with more chances of tachysystole, tachycardia, and fetal distress. Please keep that in mind. Coming to mechanical methods, so what we mostly use is a Foley's. So we put a transcervical Foley's catheter. It's very cheap. We instill.
Balloon devices are commonly used to open narrowed blood vessels. But the real question is, when should you inflate, how much, and for how long? As the balloon expands, it creates controlled pressure against the stenotic segment, improving the vessel lumen. But excessive inflation can cause dissection, vessel injury, or perforation. So the expertise isn't simply knowing how to use the balloon, it's knowing which balloon, what pressure, and when to stop. That's where clinical judgment matters.